I'm Dari Pandarsani, GP training in Glasgow. Okay. So this is the normal chest X-ray. Just to recap what we had in the last session. So we discussed about the quality of the assessment when we how we're gonna see the image is of good quality. We're gonna see the rotation. We discussed about the rotation. How we're gonna see the for inspiratory film projection and also penetration, yeah, and also how we're gonna identify that this is the normal chest X-ray based on the ABCDE approach, because it's really, if you know the normal chest X-ray, you will easily pick up abnormal one. Yes. So this is how you once we discuss how you are going to identify the abnormal chest X-ray. What we have mentioned that you always need to compare apical first right to left side. So apical right to apical left, and upper left to upper right to upper left, middle right, middle left, right lower to left to lower. So always need to compare right to left based on these zones. As we say that we're gonna use zones instead of lobes when you're interpreting chest X-ray. Okay, so suppose in this, how you gonna interpret this X-ray? So you'll say that so I'll just, I will try to interpret some of the X-ray, then I will give you space to interpret it, okay? So how you're going to interpret this X-ray? You'll say that there is right upper zone consolidation, okay, which occupied entire apical and upper zone, which limited to a fissure. This is a fissure, and it salutes the right upper mediastinum. So this is the way you need to interpret it. So the one who you are interpreting to, they will know that this is involving whole lobe, which is severe. The patient will need IV antibiotic. Yes, which is different from its only mild consolidation. So consolidation, is it only pneumonia? Is it only you're gonna say this due to pneumonia? For sure, no. What's the meaning of consolidation? Consolidation, it means that alveoli and small airways filled with dense material. So dense material, whether if it is pulse, it means the consolidation is pneumonia. If it is fluid, the alveoli and small airway also may fill with the fluid. If it's fluid, it's a pleural effusion. If it is blood, contusion, yeah. If the alveoli and small airway fill with the abnormal cells, it is the mass. So what's the differential diagnosis of the contusion? It is pneumonia, pleural effusion. It's a fluid, or it's a contusion, or a mass, abnormal lung mass. So, but there's a radiological feature we can differentiate between all of these four, yeah? So first, suppose in that first one, we're gonna focus with the pneumonia, then the rest later on. So pneumonia, usually the features of the consolidation of the pneumonia is of homogeneous opacity, like this. Look, it's an homogeneous opacity. For sure, in the early signs of the consolidation of pneumonia, it will be like it's of heterogeneous because it's an early until it involves all segmental lobe. Yeah, it's usually it's of homogeneous opacity, and it's a lobar or segmental. Suppose it will involve upper lobe, middle lobe, lower lobe. So yeah. So, and also it is limited by the fissure and also obliterates the adjacent border. Suppose in this case obliterated the right upper mediastinum. If it's in here in the middle, it will obliterate the right cardiac border. If it is in the lower, it will obliterate the diaphragm. So this is the features of pneumonia, and also air bronchogram. What's the meaning of air bronchogram? So it's like black tubular structures. It's some bronchus, yeah, bronchus filled with the air. So it is appear as black tubular structures, just like I'll show one, like this. It's just like this. What's the air bronchogram? It's like black tubular structures within the area of the consolidation. So this black tubular structure, it's a bronchus, yeah, surrounded with the opacity or consolidation. So it's not almost always you should see the air bronchogram within the consolidation to say, oh, this pneumonia. So if it's an consolidation involved, if it's extensive consolidation involved whole the lobe, so the bronchus also fill with the pus, mucus secretion, so it will block the mucus. Yeah, it will block the bronchus. So at that time, you will not be able to see the air bronchogram. So air bronchogram, it's only when it is like mild, moderate consolidation. It's still not involving the bronchus. I mean, the bronchus not filled with the pus or mucus secretion. Yeah. So these are typical features of the pneumonia. Yeah. And also, one of the most important things, you don't have to interpret chest X-ray without clinical features, because clinical feature will give you, I mean, very high amount of percentage of the diagnosis. Suppose that this patient was presented with a high temperature cough, yeah, high temperature cough. So it's different from someone like cough, weight loss, hemoptysis. So difference with, I mean, the diagnosis will give you a hint of a clinical feature will give you a hint of diagnosis. Let us come to the middle. If you look at here, what do you see here? Although this is a poor quality imaging. Why? Because it's a poor penetration. Poor penetration. When we say it, how are you going to see that's a good quality film of penetration? If you see the spinal shadow, if you see just spinal shadow beneath the cardiac. So here you cannot even see the spinal vertebrae. So it's a poor penetration. But despite of this, I mean, your clinical, the clinical features, if this X-ray has been taken due to the patient has fever and cough, clinically unwell. So if you see the answer of the clinical question has been answered, you don't have to ask for repeat of the chest X-ray due to the poor penetration. If you see, despite of the very poor under penetration, you can still see there is the opacity or consolidation here. How you're going to interpret this? How you're going to interpret this? So look, there is there's an or consolidation or opacity adjacent to the right heart border, which obliterate or silhouette the right cardiac border. Do you see the right cardiac border? No. Yeah. So if you come here, so look, there's a consolidation or opacity adjacent to the right cardiac border, which silhouettes the right cardiac border. So most likely there is a consolidation involved to the right middle lobe. Why did I say here lobe? Because I'm 100% sure there's a right middle lobe. Because once there's an obliteration in the right cardiac border, it means the consolidation involves the middle lobe. And once there's an obliteration in the left cardiac border, it means that the consolidation involves the left middle lobe, or what we call it lingulum. Otherwise, you're gonna use zone in the chest X-ray interpretation. But if you're 100% sure it's a middle lobe, like in this case, it's an obliteration of the right cardiac border, you will say there's a consolidation which obliterates the right cardiac border, most likely features of the right middle lobe. Okay, so here. If we compare, we said always compare, yeah? If we compare apical, right and left, do you see any changes? That's almost same, yeah? No any changes. If you come right, mid, normal, yeah? There's no any like abnormal densities, any abnormal changes. If you come to the left one, how are we gonna describe this? It's a typical consolidation of the left middle zone. consolidation of the left middle. I said zone, not lobe. Okay, consolidation on the left middle zone. So which it extends to the left hilum. But look, if you look at it, it did not obliterate the left cardiac border. Look, this is the clear left. You can easily trace and outline the left cardiac border. Look, it did not obliterate it. That's why it's not a middle lobe. It's the consolidation of the left middle zone, not lobe. If you said middle lobe, it should obliterate the left cardiac border. Look, you can easily trace the left cardiac border. Look, it's very clear, left cardiac border. Okay, so it's the consolidation of the left middle zone, which extend to the left chest wall and left iliac, left hilar region. And there is an air bronchogram within the consolidation. So feature consistent with pneumonia of left middle zone. So let us discuss a bit of typical pneumonia. A typical pneumonia, how are you going to differentiate between the typical pneumonia of community-acquired pneumonia and a typical one? Usually the patient of the atypical pneumonia, the patient is ill, clinically, you will see the clinical features or in the notes, the patient is unwell, ill, high inflammatory markers up to the sky, and the news chart is low, very, high, low oxygen, respiratory, tachypnea, tachycardia, everything. So the patient is looking very unwell. But despite of that, chest X-ray, it's not that severe if you correlate with the clinically. So this is one thing, the clinical feature. Okay. The second thing, it is not of lobar or segmental distribution. Okay, suppose this X-ray. So this X-ray, the patient came with unwell, same high inflammatory markers, and the patient confused. Okay, so here, if you see the chest X-ray, we'll see this Apache consolidation in both mid zones. Look, why I say patch consolidation, this is not that one consolidation involves one of the lobar or segmental area. This is only patchy consolidation, only patch here. Okay, so this is a patchy non-lobar, it is in non-lobar distribution. Why? Can you see this is, it's whether it is involving the upper lobe, middle lobe, lower lobe? No, you can't. You can't see, you can locate the site of this consolidation in a lobar or segmental area. This is the second thing. The third thing, so it's not obliterating the border. Suppose this consolidations, here patch consolidation does not obliterate the cardiac borders, or if the patch consolidation here, it will not obliterate the diaphragm, it will not obliterate the mediastinum. So this is another features, okay? And if it's very severe, it might. But see, these features you can easily distinguish from the atypical to typical one. Here, there's another example. This one, this was, this patient came with chronic cough, hemoptysis, weight loss. Okay? So this, if you look, if you compare both zones, how are you gonna interpret this? If you see this is the left upper zone, left apical, and this is the right apical. And this is upper, left, upper, right. If you see there is a patchy consolidation. Look, patchy consolidation, this one consolidation, and this another consolidation, and there's another consolidation here, and this is the bulky right hilum, yeah? So here is the multiple patchy consolidation involving the right upper zone and mid lower also, okay? So, and also there is a bulky, or we can say another well-defined opacity involving in the right hilum. So these are features of the primary TB. Have you heard about the primary? So we'll just shortly about the primary and secondary TB. Primary TB. The features of the primary TB is usually like focal consolidation associated with the ipsilateral pathology. Yes. And where is the common location for consolidation of the primary TB? Usually it's middle and lower zone. Have you heard about the gone focus? That one with the focal area of the consolidation and ipsilateral lymphadenopathy. So these are features of the lymphadenopathy. So here, although this is involving the right upper zone, we say primary TB mostly occur in the middle and lower zone, but it could occur also in the upper zone. So here it is a patchy consolidation involving the right upper, right upper. This is one, this is two, and also involving median and lower zone. It's only patchy consolidation associated with the ipsilateral lymphadenopathy. This was features of the primary TB. Here. How you are going to interpret this? We say compare, yeah? If you compare. Here, in the right left, if you compare left apical to the right apical, do you see any changes? Suppose look, if you just look at, as a glance to this CXR, you'll say, oh, it's normal. But if you go systematically, as we say, compare right to left, zone by zone, you're not gonna miss it. If you see here, left apical and right apical, do you see any changes? For sure, there's a changes here. There's a density here. There's a dense shadow in the apical, right apical zone. Okay, so here there's a even there is some sort of the cavities inside it. Look, you see these cavities? The cavity. So how you're gonna describe this this chest X-ray? We say there's a heterogeneous opacity or consolidation. So it's a hetero, non-homo. Homo, what does that mean, homo? But if it's just like this, it is just like homo. Hetero, it is mean mixed between the low and high density. So it's a heterogeneous opacity involving the right apical zone, and even there is a small cavitatory lesion inside it. If you see this small cavity, yeah. So what does that mean? If it's cavity within the opacity, it means that it's a reactivation. So here, for sure, you are not be 100% sure this is the TB. You are gonna say, oh, it's a TB. No, you will say just interpret as heterogeneous opacity in the right apical zone. Features could be of pneumonia, or the TB cannot be excluded. Why? Because these are typical location and feature of the reactivation or secondary TB. We say it why? Because it's first usually secondary TB occur in the apical zone. And so heterogeneous, and also cavitation. One of the cardinal features of the reactivation TB, I mean activity, if there is cavity-like lesion. If you see there's a cavity, small cavity, okay? So you're gonna just advise to do an sputum for acid phosphate to exclude TB. Here, if the TB, spread through the blood, what we call it hematogenous dissemination, yeah? So what will be, how are you going to describe this? As a miliary TB. But how are you going to describe it? You all know that it's a miliary TB, yeah? But how are you going to describe it? You're going to describe it as a bilateral, widespread, fine nodules of 1 to 2 millimeter. Very fine, 1 to 2 millimeter, scattered throughout both lungs. Look, scattered throughout both lungs. So miliary TB could occur during the stage of the primary TB or reactivation TB. So they have very poor prognosis. So these of miliary TB of fine nodules scattered was separately bilaterally throughout both lungs. And then you can say that here both costophrenic angles and no other opacities can see, and cardiac shadow with a normal. So there's only miliary TB. Here. Here also there is, if you compare, same, upper, there's nothing. If you come to the middle zone, what we're gonna describe this? It is a well-defined, yeah, so it's a well-defined thick wall. Look, so you see the well-defined thick wall cavitatory lesion. Where? In the right parahilar region, or what we call it in the mid-zone of the right lung. Okay, so why I said thick wall? Because thick wall, it's because if you just measure this, it will be more than like it will be more than 4 mm. If it's less than 4 mm, we'll say thin cavitatory lesion. If it's more than 4 mm, thick cavity lesion. So this cavitated, why is it cavitated lesion? It's not only an opacity, because look, there's a well-defined opacity, but there is a cavity on it. So this is a well-defined opacity, and there is a cavity. You see, this is a cavity within the opacity. That's why you're gonna describe as a well-defined thick wall cavitatory lesion in the right mid zone or right parahilar region. So usually, what's the meaning of cavity on it? The cavity is usually the gas filled space within the lung parenchyma. Yeah. So cavity is usually formed by the necrosis of the lung tissue. So if you see the cavity, usually it will be the features of the maybe abscess, malignancy, or fungal infection. Yeah. So these patients need to be further investigated for CT scan. So to exclude lung malignancy, but could be of abscess also, or fungal infection. This one. So here, if I tell you the clinical feature, so really clinical feature is very, very important to consider it before interpreting. So this patient came with the history of the blind trauma to the chest wall. Blind trauma to the chest wall. So just a few hours ago, okay? And this is the chest X-ray. Okay. So how are you going to interpret this? So this is, if you see, there is it's a heterogeneous, less dense opacity in the right lower zone, which did not obliterate the right cardiac border and even the right diaphragm. And there's some sort of this small right pleural effusion because the blunting right costophrenic ankle, yeah? And okay, let us describe more about this consolidation. So it is of less dense. If you compare this with the cardiac shadow, it's of less dense. So it is of less dense, irregular opacity in the right lower zone, which did not obliterate the right cardiac border and diaphragm, associated with multiple displaced posterior fractures. Posterior rib fracture. Look, if you see, this is how are you going to know that this is a rib fracture? I know this is very clear. But sometimes how you are going to know this is undisplaced rib fracture? How? Because it's very difficult, to pick the undisplaced fracture. How are you going to know? So you're going to usually trace the rib. Suppose this is the ribs, yeah? Just trace it. Just trace the outline of the rib. Look, this up. Look, this is discontinuity. If you see there's a discontinuity or irregularity, it means it will be a fracture. So this is also a bit displaced fracture. This another clear displaced posterior fracture. Another clear displaced fracture. This is a bit. This is undisplaced. So suppose if this was the only fracture, how are you gonna know? Just go with the continuity of the lining of the rib. Look, you will see discontinuity and irregularity. You will pick up the fracture. So here, are we gonna describe as a consolidation of like pneumonia? Is it like consolidation of pneumonia? No. Why? We will say this is a consolidation of contusion. So now we are going to start with the pleural effusion. Okay. So chest X-ray. I mean, it's very common and useful examination to assess the presence of the pleural effusion. I mean, for the pleural effusion to be evident in the chest X-ray, it needs at least 25 ml of the fluid, yeah, to become evident in the chest X-ray as a obliteration of the costophrynic angles. We have another projection, which is we call it lateral decubitus film, in which the patient lie in the lateral position. I mean, even small amount of the fluid can be evident when the fluids lie in the most dependent part. But this is really very rarely can be done, this projection, due to the availability of the, I mean, ultrasound and even the CT scan. But I mean, the lateral decubitus film can easily identify pleural effusion even with a small amount. Okay, so here. So if we said, I mean, how are we gonna interpret? Just, I mean, scan apical, upper, middle, lower, nothing. And if you look at the costophrynic angle here, it's a sharp costophrynic angles. If you come at left side, it's a blunting costophrynic angles. If you differentiate, if you just compare left to right, the right one is sharp costophrynic angle. If you compare the left one, it is blunted. It means there's a small pleural effusion on the right side. Here. If you see this straight, here there will be, here it's clear. Yeah, it's clear. I mean, if you compare the lower left to right, the right lower zone, it is, I mean, there's a homogeneous opacity occupying right lower to mid zone, which obliterate the right cardiac border and diaphragm and costophrynic angle. And there is meniscal sign. Maybe you've heard about the meniscal sign. At the top of the pleural fluid, there is a meniscal sign. What's the meaning of meniscal sign? It means it's a cardinal sign that this homogeneous opacity, it is of pleural effusion. So this, with the meniscal sign here, if you see, where is it? Here. If you see this at the top of the pleural fluid, there is we see concavity. Look, it is a concavity at the top of the pleural fluid and gently sloping down from laterally to medially, like this. Okay, so this is the cardinal features of pleural effusion. Okay, so when you spot out that there's a pleural effusion, you have to look at other features to know what is the cause of the pleural effusion. So if there is any like consolidation or density, like in this feature, in this case, the patient, I mean, had this X-ray due to the progressive shortness of breath. Okay, so look, this is a pleural effusion. You spot it out. Yeah, here, if you look at here, look, there is an upper zone. Look, there is an upper, upper lobe vessels dominant in the upper zone. Do you look at here? There is a dominant upper lobe vessels. Ideally, what will be, I mean, ideal in normal lungs? In normal lungs, I mean, the lower lobe vessels look more dominant. Why? Because there's a blood flow is gravity dependent, yeah? But when upper lobe vessels become prominent, this is usually due to the pulmonary venous hypertension, yeah? When the blood backs up into the upper lobes and traversing the normal blood flow. So in this case, there were features of the heart failure. Why? This one, pleural effusion and upper lobe vessels. As we said, when the upper lobe vessels become more dominant than the lower zone, it's one of the features of the heart failure. And also, you can, I mean, because of the right cardiac border is obliterated, you cannot, accurately measure the cardiac size, but you are assuming here it's a enlarged cardiac shadow. Why? If you just look, if you measure it from here, look here, cardiac border until here, it's for sure it's more than even 60% of the CT ratio, which is cardiothoracic ratio. Yeah. So here we have the cardiac enlargement, upper lobe vessels dominant, and pleural effusion. So these all are features of the heart failure. Another example. So this is the meniscal stance, which we mentioned now. This is a concavity in the top of the pleural fluid, sloping down from medially to laterally. Look, meniscal stance is the cardinal feature of the pleural fluid. Here, there is another example of the massive left pleural effusion with displacement of the trachea and heart to the contralateral side. Yeah. Here, if you look at here, we have the early signs of the heart failure and we have the advanced stage, yeah, advanced signs of the heart failure. If it's an early signs of the heart failure, what we call it in the, interstitial edema, we have the interstitial edema and alveolar edema, yeah? If it's an interstitial edema, it means still we can see the early signs of the heart failure in the X-ray, like this patient. Okay. No, okay, actually, this also, we can also see a late sign also. So here, if you see upper lobe vessels dominant in the upper zone, upper lobe vessels dominant. If you compare to the right side, if you compare to the lower vessels to the upper vessels, you will see upper lobe vessels dominant. Okay, so this is one of the features of the heart failure. Okay, here it's clear upper lobe dominant. Here, especially here. This is one zone. And also there's another early signs of the heart failure. This is septal line. Do you see this septal line? This is short horizontal line across the costal chest wall, or even in the lower side, even you can see it here. Here, look. Here. So this is curly, we call it curly B lines. Okay, this is the second features of the heart failure. And also, you see cardiac size. Look, cardiac size enlargement. This is definitely more than 60% of the CT ratio. And also pleural effusion. Look, blunting of the both costophrenic angles bilaterally. This is features of the pleural effusion. And also we have this is our interstitial edema. Alveolar edema, if you see the alveolar edema, maybe you see another example. So this is the same. This is the same, just, being colored just for educational purpose. So this is the upper zone results. Look, just going back again. Upper zone results. Look, especially here is very clear. Here, look, this is upper zone results. Here, and then this is the septal line. This is the septal line. This is just more clear. And this is the enlarged cardiac shadow. And here it is the and here's the airspace shadowing. Airspace shadowing, it means it is alveolar edema. How you are going to describe as alveolar, edema? If there's an alveolar edema, you're going to see density radiates symmetrically bilaterally from hilar region toward the periphery. Have you heard about the path or butterfly distribution? So this is of airspace shadowing. You can describe as airspace shadowing or densities symmetrically radiating from periphery, from hilar region toward the periphery in a path or butterfly distribution. When it is only interstitial edema, you can see the upper lobe vessels prominent, septal lines, and also when it's alveolar edema, we can see the airspace shadowing. These airspace shadowing radiate from the hilar region toward the periphery, just like this. This is very clear. Look, this is the green color. It's called airspace shadowing. Okay, so let us discuss about the other topic, which is the pneumothorax. If anyone, even medical student, if missed such X-ray, no one is gonna defend you, because this is, emergent and safe living X-ray need to be well spotted and diagnosed. Okay, so this, as you described, it is a, radiolucent. It's a radiolucent. All left hemothorax is radiolucent. Radiolucent means it is a black. So all left hemothorax is black, okay, with no lung marking. Do you see any lung marking if you compare to the right hemothorax? No. Look, the right hemothorax, it is of vessels and the normal lung with vessels, but here you can't even see any lung marking and vessels. So it is all left hemothorax. It's radiolucent and no devoid of the lung marking. And then it is here, it's a pleural line. The same with pleural line, which the line pencil thin line, which separate between the lung markings to pleural. So here, if you see here, the left lung is completely collapsed. Look here. Only this is the dominant part of the left lung. This is the right cardiac shadow. This is the left lung. So the left lung is completely collapsed. Okay? The mediastinum and heart shifted to right side. So this, to be honest, this patient, it's an emergent condition. Even, you don't have to, if you face such patient in the ED or worse, you don't have even to request for chest X-ray. So the patient has a clear sign of the tension pneumothorax by the tracheal deviation, and the patient's very breathlessness. So this is a very clear feature. And as I said, you don't have to miss such features. Otherwise, no one is going to defend you. And this is just for clarification. This is the right cardiac aorta, and this is the diaphragm has been depressed. And this is the left lung, which has been completely compressed. And this was the shifting of the trachea and heart. Okay? Here, if you see here, this is same, another features of pneumothorax. So here, this pneumothorax extends from the apical toward the lower. Okay, so here there is rule. Maybe you have heard it about rule of two, based on Bridge Thoracic Society guidelines. You can define as small or large pneumothorax based on this width of the size of the pneumothorax at the level of the hilar. So this is the hilar region, yeah. So you're gonna measure the width of the pneumothorax at the level of the hilum. If it is less than 2 centimeters, it means it is of small pneumothorax. If it's more than 2 centimeters, sorry, where's that? Okay. So if it's less than 2 centimeters, it's small pneumothorax. If it's more than 2 centimeters, it is of large pneumothorax. So here, suppose here, this is more clarification. So this is the hilum, and you're gonna measure the width of the pneumothorax. If it is less, as this is more than 2 centimeters, so it is of large pneumothorax. Okay. So because if it's small pneumothorax, maybe it can be treated as a conservatively, and large one needs the drain. Yeah. Train. Okay, so here, if you look at here, it's good. You will spot it. You spot that there's abnormality in the left, in the right upper zone. If you compare the left upper to the right upper, so there's a well-defined. Look, just a trace outline with the mouse. So well-defined of irregular border shadow of maybe 6, 7. So we're gonna just measure it. Electronically. So it's a well-defined, irregular, round shadow in the right upper zone of maybe 6, 7 centimeters. So we're going to measure it. And contains of cavitation. Look, there's lots of cavitation in the upper part of the shadow. So there's a big cavity here, and there's another multiple small cavity in the upper part of the opacity. So that's the way you get. Even if you don't know what is this, if that's vena, at least try to interpret it and give the differential diagnosis. Suppose in this, it's a well-defined irregular border. Look, why I said irregular? Look, because it's not regular one. Look, it's just go there and there and here. So it's a well-defined because I can easily pick up a round shadow. Yeah, so well-defined irregular shadow in the right upper zone of, suppose 6, 8 centimeters in the right upper zone, contain cavitation in the upper part of the shadow. So, then say, is there any other consolidation? No. Any other? Why you have to comment? Suppose in the hilar region, is there any lymph node, anything, any dense, bulky? No, I can't pick any density. If you compare, it's a bit the patient's rotated to the left side. That's why here in the right hilum you see a bit denser, but otherwise the density and the both hilum or bulk, nothing. The same density, same bulkiness, same level. And this patient has undergone the surgery, that one CABG, bypass graft surgery. And that's why you can see the sternal wires and clips. This is clips and wires, okay? Otherwise, to be honest, the left cardiac border, look, it can easily outline the left cardiac border. There is no any like obliteration, and this is the right cardiac border. There's no obliteration. This right diaphragm, and we can see the left diaphragm and costa triangle. So these features were of cavitated lung mass of lung cancer. So these we're going to give a diagnosis, differential diagnosis of, could be of lung cancer, could be of TB, could be of abscess, could be of fungal mass. But to be honest, these features all goes more likely of lung cancer. So we're going to advise in your report for further scanning, which is the CT scan, yeah, for better clarification, differentiation. This one. So this patient was presented with the, smoker, long-term smoker, presented with the cough and finger clubbing. Okay? What do you see? Yeah. It's a well-defined, yeah. It is a well-defined mass of maybe 5-6 centimeter at the right middle zone at the level of the hilum, which is of spiky. Can I maximize it? I think I can maximize it. Yeah. Yes, I can. So look, this is the same. You can just maximize it. So look, it is a well-defined mass at the right middle zone at the level of the hilum, but it's of spiky. If you look at it, it's not a regular border. It's of spiky. Look, do you see that spiky one? Spiky border. It's a characteristic features of malignant. It's a malignant mass of lung cancer. Yeah? So the spiky borders is of cardinal features of the lung cancer. So this this mass need to be investigated with further imaging CT scan for stagings and confirmation. Okay. And has anyone any question regarding all what we have discussed of common abnormalities? Hope it was a very helpful and interesting session. Any question?
Thank you so much, Pavan, for that session. Thank you. It was really useful.
Yeah, you're most welcome. You're all welcome. Thank you for all your attendance.